You guys did a study using this compound that actually improved anxiety and depression significantly. So Dr. Dom D'Agostino, tell me a little bit about this and how people can potentially use it.
Yeah, I think what you're talking about is research that we did. I think it started in maybe 2013 or 14, but we published it in 2015, which is using exogenous ketone therapies, looking specifically at anxiety behavior and anxiety, tied to anxiety disorders. And this was largely came about by doing seizure studies using various ketogenic agents, exogenous ketones. And prior to, after treating the animals with these ketogenic agents, prior to putting them into a hyperbaric chamber to look at these induced seizures, we realized that these animals were much easier to handle, and they were calm, and they allowed us, it made the experiments much easier because it seemed to attenuate their fear response. And also improve their social ability when we would administer the subjects and put them back into the cages with the other animals prior to moving them into the chamber for the seizure experiments. So it was my wife, actually, Dr. Chilla Ari, who is a behavioral neuroscientist, said, we should study this. So I had a little bit of some funding at the time, a small amount to study this. And we did the Elevated Plus maze and a variety of different very classical standard tests that you do in rodent models to assess, as pharmaceutical companies will use similar tests for testing things like Xanax and anti-anxiety medication. So we did these experiments and we tested ketone salts, we tested ketone esters, and we tested the combination of ketone salts with MCT oil, which seemed to be, that was the best performer for the anti-anxiety effect. And essentially what we did, or one experiment, is that we administered the ketogenic agents and then we put them on this Elevated Plus maze where they have the opportunity to go inside a little cave or come out on a platform, which is essentially like a catwalk where you can fall off either side, but you're exposed to the environment. And animals that are more anxious or have an accelerated fear response or exaggerated fear response, they'll go back into the cave and essentially hide. And if they're more social and they have exploratory behavior and they're more chill and relaxed, they come out and hang out on the open arm. So it's called but it's elevated. It's Elevated Plus. They don't like to be on high. So we did this experiment and we conclusively showed with really good data that we published in several articles and journals, because we then went on and looked at the mechanism, and it was tied to adenosine receptor signaling and some other mechanisms. We don't have to talk about that. The take-home message is that therapeutic ketosis that was achieved with exogenous ketone supplementation using a ketone salt that's combined with MCT. We also saw an effect with ketone esters, but it wasn't as great as simply a ketone salt and MCT.
So no dietary ketosis at all?
No dietary ketosis.
Not having to do a keto diet?
No. There were, the rats were eating standard rodent chow. And how we did the experiment was, and this was an acute effect, so we would administer through an intragastric gavage, basically just tube feed them an amount of ketones that would rapidly put them into therapeutic ketosis within 30 to 60 minutes. And then we would do the experiment over a series of hours after that. So, and it would also follow the pharmacokinetics of the administered agents, which would be 4 to 6 or 8 hours, depending upon the agent. But we observed that there was a remarkable increase in the amount of time in the open arm, and we observed that these animals were much more calm, much more social, and they didn't have the exaggerated fear response. When you would grab them, they wouldn't try to bite you.
Before we get into all the craziness with Dr. Dom D'Agostino, I popped the link down below for 30% off your entire first grocery order through Thrive Market. So the cool thing about Thrive is they vet all the ingredients, all the products that are coming onto their digital shelves, so to speak. They literally reject thousands of ingredients and thousands of products because they don't want garbage being sold. So they really do put their best foot forward when it comes down to providing quality food. So that is a 30% off discount link for your entire first grocery order, plus a free $60 gift when you use that link down below. So load up the grocery cart, get your groceries ordered, and get them delivered right to your doorstep at 30% off. So that link directly underneath this video, the top line of the description.
So we observed this for years using these ketogenic agents for our seizure experiments, but it was my wife that was like, well, they're obviously less anxious. So I think if we study this, we would see a pretty remarkable, significant effect. So when we did, we saw the anxiolytic effect, the anxiety reducing effect in these animals, and it was the remarkable thing that these animals were not on a ketogenic diet. And the other thing was that we use MCT and ketone salts, which are readily available, commercially available. They're safe. We did long-term studies with these agents, looking at liver health and looking at, doing a comprehensive metabolic panel, CBC, CMP, and at very high dosages, these agents are very safe to consume to produce moderate to low therapeutic ketosis that can be sustained throughout the day with 2 or 3 administrations throughout the day. So, but this was a single administration, and we looked at the acute anxiolytic effect of these agents, and we saw a remarkable effect that was along the lines of a moderate dose of a benzodiazepine drug like Xanax. So if you look at, testing Xanax on various animal models, the amount of time that they spend in the open arm would be similar to these ketogenic agents. So it kind of, I think that in some ways may have spawned, because it was an earlier study that we started and published 10 years ago. Since then, the emergence of metabolic psychiatry has really blossomed, and there was studies that were done before that with fasting and various ketogenic diets. But I think the observation that therapeutic ketosis is independent of dietary restriction, and that maintaining the elevation of ketones had an anxiolytic effect, that was sort of new information. And since then, I think we have 40 to 50 registered clinical trials on clinicaltrials.gov looking at therapeutic ketosis. I would say about half of them or 2/3 of them are using dietary ketosis, but I think about 1/3 of them are actually using ketone supplementation. So this is more of an innovative approach, and they're not mutually exclusive. You could do a ketogenic diet and further augment therapeutic ketosis with a ketogenic agent. So I think that's an approach that investigators, and these are top-tier institutes doing this research, largely funded by, and have to credit Jan and David Baszucki from the Baszucki Foundation, or Baszucki Group, or Baszucki Brain Research Fund is funding $50 million of studies in this area of research, and it's rapidly emerging, and it's probably one of the most exciting areas of research emerging with dietary therapies.
Would your hunch be that it's the anti-neuroinflammatory effect, or do you think there's alternative fuel source effect? Like, is it sort of metabolic theory in terms of just, hey, this is an energetic disease, an energetic issue? I know with anxiety, it's a conversion of there could be with insulin resistance sometimes a dysregulation because of fructose from glutamate over to GABA, right? So you kind of have this. Which is extremely important for just remaining calm and feeling calm. So where do you think mechanistically this ties in? And I say this because I think this could help people if they're anxious, if they understand the mechanisms, then we can reverse engineer some things and think about how other ways we can do this.
Yeah. I have a lot of thoughts there. One word of caution is that higher levels of ketones can actually cause an anxiogenic effect. But the sweet spot seems to be about 1 to 2 millimolar of ketones in the blood. And I do have a few emails from patients that achieved high levels of ketosis with various ketogenic agents, and they feel that it could have triggered mania, right? Because you have too much energy. It's almost like you have energy toxicity to the brain. You have too much energy, and that could trigger. So, but that's very context specific, and maybe more specific to bipolar, where mania could be triggered. However, I will say, like with Matt Baszucki, he was drug resistant, drug refractory to therapy for his bipolar and therapeutic ketosis, which was implemented with a team at Harvard largely with being treated by Dr. Christopher Palmer, helped him achieve and maintain remission in therapeutic ketosis, and that was dietary ketogenic diet. And I think Matt occasionally uses ketogenic agents too if his diet becomes a little bit loose. But when in regards to mechanism, and that's in regard to brain energy, we know that within 30 to 60 minutes that you can change brain energy metabolism with exogenous ketones. So this is not animal models. Now we have human trials where we do MRS and we do, functional magnetic resonance, fMRI, and various other techniques to show that not only brain energy is changing, but you can also, the networks in the brain are changing. So the neural networks are changing pretty remarkably in response to therapeutic ketosis. And previous work done by Stephen Cunnane, he did a dual PET scan of glucose, FDG PET scan, but also a ketone PET scan. So basically radio labeling glucose and ketones, and then looking at the use of brain energy from these two fuels in the context of mild cognitive impairment. And as we age, the brain has a decreased ability to use glucose as an energy source, and that's not the case for ketones, meaning that as we age, our ability to use ketones as an energy source is pretty much maintained. So ketones can largely rescue the brain from glucose hypometabolism. And there's a theory that in certain psychiatric disorders, particularly disorders associated with neuroinflammation, but maybe not, that could be a comorbidity factor, but that glucose hypometabolism is part of sort of the cascade of things that are happening with psychiatric disorders. But with therapeutic ketosis, with exogenous ketones, you have a couple things going on. You have the immediate use of a fuel that probably has a higher energetic potential than glucose. You have that. And the same year that we published that, we published another paper in maybe a year after that in Angelman syndrome and a couple other papers looking at glutamic acid decarboxylase 65 and 67, the enzymes GAD 65 and 67. So they convert glutamate, which can cause, brain hyperactivity and anxiety, to GABA, which is like the chill and relax neurotransmitter, gamma aminobutyric acid. So we make GABA from glutamate with the enzyme glutamic acid decarboxylase. We knew that on a ketogenic diet, GAD would increase, but we didn't know that when you use supplemental exogenous ketones, it also increases the protein. If you do like a PCR, the protein GAD 65 and 67, I think they both go up. So one's more important than the other. But the important thing is that we convert more glutamate into GABA when we achieve and maintain therapeutic ketosis with dietary ketosis and with supplemental ketosis. So you have brain energy metabolism is increasing, the neuropharmacology of the brain is increasing, specifically an elevation of GABA. We haven't looked at dopamine and serotonin yet, but we need to do that. And then you have, over a course of time, but this would not factor into the experiment that I talked about, that you would have a reduction in neuroinflammation. There's also adenosine receptor signaling is also an important thing. We know that caffeine's an adenosine receptor agonist, but adenosine agonists can also have a calming effect and kind of make you sleepy too, but it depends on what receptor you hit, but can have a pretty pronounced anxiolytic effect. So the ketones seem to be working through adenosine receptor signaling, GABA, brain energy metabolism, but also neuroinflammation. And then we're also looking at, epigenetic signaling and various neurotrophins and things like that. But that's a little bit more downstream and wouldn't happen within that temporal correlation that we're talking about in the time frame of hours after administration of the agents. So I think it's multiple things maybe also working in synergy. As brain energy metabolism increases, that ramps up and stimulates the TCA cycle, also the Krebs cycle, and many neurotransmitters are actually from that, from alpha-ketoglutarate, for example. Like your glutamate comes from the TCA cycle and GABA comes from So when you stimulate your metabolism and you stimulate the mitochondria, many neurotransmitters are made, in the mitochondria. So monoamine oxidase, for example, is actually a mitochondrial enzyme. So MAO, monoamine oxidase, will increase and be more active as a direct result of mitochondrial metabolism. And when you increase ketones, that stimulates ATP production in the brain, overall metabolism. and that increases the TCA cycle where your neurotransmitters come from, but also various enzymatic pathways that are coupled to energy activity are coupled to that, that monoamine oxidase and mitochondrial metabolism. So these are all things that need to be appreciated and considered and also deconstructed. And there's a number of investigators, looking at that now. And
I mean, this is truly why metabolic health, yes, ketosis, exogenous ketones, like all things that people could very easily do and very easily get or achieve.
Yep.
But also just the picture of what happens metabolically in your body is almost as important, if not even more important than what we've been thinking about for the brain. It's just more so about like, hey, think metabolism first. I'm seeing more and more people in the neuropsychiatry and neuroscience field actually pivoting, being like, you know what? Like all this is fine and dandy, but metabolism first.
Absolutely. I was trained as a neuroscientist. I was in a neuroscience program, but also did a PhD in neuroscience, but also in physiology and had to take courses for both. And I studied the neural control of autonomic regulation. So how our bodies, how our brain controls our physiology. So I had to understand, systems physiology and everything. So there's no doubt, I think the whole concept behind metabolic psychiatry is that changing your metabolic physiology and the fuels that you use has a profound effect on changing brain energy metabolism, but also these metabolites are powerful signaling molecules that have a wide range of effects on the neuropharmacology of the brain. I mean, that's a statement that nobody would, challenge, right? And I think that, when I took neuroscience as a PhD student, we didn't talk about it in that way. We talked about, the brain uses glucose for energy and maybe like lactate under some situations, but I don't even think we discussed ketones and didn't discuss how food impacts mood and how just overall metabolism. But it was drilled into us that the brain is incredibly metabolically demanding. And if there's any compromise in the fuel to the brain, the glucose or the oxygen, that would cause major consequences. So another area of research that I was interested in is like ischemia, like stroke and hypoxia. So these are things that I kind of studied too. In my postdoctoral, we did, actually that got me interested in lactate before ketones and alpha L polylactate, which is an oral form of lactate you could consume as a therapeutic. And then there's sodium lactate too, which is used. There's good data to show with brain injury. But then I had some nice data for that, but then I pivoted to ketones. And then in the same experimental preparation, which was a hippocampal brain slice preparation, the ketones were remarkably mechanistically outperforming anything that I studied. So I moved the basic science research into animal models. And unlike drugs where you get like a wide variety of different responses, the ketones like ubiquitously just seem to be therapeutic in so many different scenarios. So seizures first, but then we moved it to many other situations. And now we're setting up to do some brain injury models. And I think with brain injury, you have a hyperglycolytic effect immediately after, and then you have a protracted reduction of glucose use by the brain, glucose hypometabolism. And that glucose hypometabolism in patients that had concussions, traumatic brain injury, that glucose hypometabolism and neuroinflammation is tied to psychiatric problems. So I'm very interested, especially in warfighters and NFL players and just, people that most injuries with TBI, it comes from a fall, believe it or not, younger people and older people, and then car accidents or something hitting them. And then, so there's a wide variety of things that can cause a TBI. But the important thing is that you have this glucose hypermetabolism, like right after, and then this protracted, and ketones can intervene in both cases. So you can mitigate there's research right now using something called 2-deoxyglucose, which inhibits glycolysis for that immediate, once you get hit. Or theories and some preliminary research on that. And then after you get hit, then you have low glucose metabolism in the brain, and then that's associated with psychiatric illnesses, PTSD. Also, that is a trigger for substance use disorder. They're the theory for that. So people who have had traumatic brain injury, they feel anxious, they feel depressed, and they go to alcohol. They go to
alcohol can bypass and get into the mitochondria almost as an energy source via that same backdoor mechanism that ketones kind of can. So are they almost like self-medicating in a way where it's giving their brain an energy that they're not even realizing it is, making them almost functionally alcoholic in a way?
Absolutely, yeah. So when you consume alcohol, when you consume ethanol, it gets metabolized in the liver by alcohol dehydrogenase, and then it gets metabolized to aldehyde dehydrogenase. So you form an aldehyde that's toxic. So ethanol is very toxic to the liver, and then that gets in circulation. But when you consume alcohol, actually it generates acetate, and acetate gets into circulation, and that acetate is actually, believe it or not, actually I'm interested in acetate. It's actually a pretty good source of energy for the brain. And acetate, you can get that from apple cider vinegar, is acetate. So when you take apple cider vinegar or acetic acid, that you're actually giving your brain a form of energy that you can use. But with alcohol, you're basically taking something that's very, very toxic and generating a metabolite that gets into circulation that's not insignificant. And then the dependency of alcohol is tied to the generation of acetate. So when you stop alcohol consumption, alcohol hits the GABA receptors and dopamine, and it does a lot of nasty things to the brain in regards to dependence, which can produce withdrawal symptoms. But that's in part due to the alcohol-induced generation of acetate. And also there's other pathways associated with GABA and dopamine and things like that. But that acetate is a critical role. So I think there's sort of an opportunity there to intervene with another metabolic substrate. So that could be beta-hydroxybutyrate. So you can greatly attenuate alcohol withdrawal syndrome and get people off alcohol, the dependency, by intervening with a ketogenic diet or exogenous ketone therapy. So this has become a pretty hot area of research. Years ago, I was on, I think, 2 different PhD dissertations that brought this to my attention. And I think the data in animal models are compelling. The amount of emails that I've gotten from people to get them off of various substances, primarily alcohol, has been pretty remarkable with ketogenic diets and usually exogenous ketone therapies. However, we can also talk about so one thing to consider when we talk about exogenous ketones to mitigate alcohol withdrawal syndrome or alcohol use disorder is that commercially on the market, there's an exogenous ketone 1,3-butanediol and then 1,3-butanediol associated esters. So in theory, 1,3-butanediol is probably potentially a good replacement for alcohol. However, 1,3-butanediol actually follows that same metabolic pathway in the liver. So it gets metabolized by alcohol dehydrogenase. It produces a short-lived beta-hydroxybutyrate aldehyde. And if you saturate aldehyde dehydrogenase, you start building up toxic aldehydes. So it's dose-dependently can be very toxic. And also 1,3-butanediol can produce dependency just like alcohol. But it's less toxic, but it is potentially... It's a dimer. It's an alcohol dimer. So it is a diol, 1,3-butanediol. And it's in most of the commercially available exogenous ketone supplements, except ketone salts. That is the exogenous ketone that people are using. So it could be, however, it would be better to use an alcohol-free exogenous ketone, like a ketone salt, an MCT. And there's other things that are being tested now, experimentally, like triesters and alcohol-free formulations, like liposomal formulations. So I think these things have incredible potential for a major problem that we have in psychiatry, because many psychiatric patients, it's triggered by some kind of substance use disorder, or because they have a psychiatric illness, they kind of default to self-medicating with various substances. So I think this is something that's not talked about, but all psychiatrists know it. Even my sister, she's a practicing clinician, and she tells me stories, quite a lot of stories. But an important thing is that you have the ketogenic diet, exogenous ketone supplementation, including ones that have 1,3-butanediol, but that's an alcohol, and it can be toxic and it can produce dependency. But then you have other ketogenic agents like ketone salts and even MCT and various formulations that can be used as part of a comprehensive, approach to reducing your alcohol and getting off of alcohol. So I'm pretty passionate about that because I think there's a missed opportunity historically to recognize this. And I think we have a great opportunity ahead of us for developing protocols to get people off alcohol.
Yeah, man, just for psychiatric conditions in the first.
I'm not super anti-alcohol. Like I do, I consume maybe a couple glasses of wine per week. Dry farm wines are just like, very lower alcohol, very, low sugar, obviously. So I'm not against, but I just, alcohol use disorder is such a massive problem. Substance abuse is such a massive problem. So this needs to be a tool in the toolbox of clinicians to help people get off these drugs that cause a lot of damage.
Just as a sort of a guidebook for people, what kind of ketones should they shop for? I mean, if they're looking to get these effects that we talked about, because it's significant. This isn't like, hey, this might help you a little bit. This is significant stuff. I'll come right out and say it because maybe you don't want to say it. I don't think 1,3-butanediol is something that people should really take. I personally am just like, personally, I don't think that's the one to go with. But they've got like things like ketone monoesters, and in very layman's terms for people, and ketone salts. And then like, what dose should they be kind of playing with? Like in grams, or like what kind of, where should people be?
Yeah, I get this question a lot. So just yesterday we published a paper it's like divergent effects of various ketone supplements on, liver and other health markers. And it's important for us to study because we want to ensure that we're developing the optimal therapeutic ketosis approach for certain disorders. And taking a step back, in the early days, we really just had 1,3-butanediol. I'm talking about back in the 70s and 80s. So it is this reliable agent that it's a little bit archaic, but it is an alcohol. It's a diol, that when consumed, it follows the same pathway of ethanol to produce reliably an elevation of beta-hydroxybutyrate in relatively small amounts. And the more you consume, it's not like you don't, the levels don't titrate up. You reach a level of saturation. And once you reach a level of saturation of 1,3-butanediol converting to beta-hydroxybutyrate, you are saturating the aldehyde dehydrogenase, but alcohol dehydrogenase, but also aldehyde dehydrogenase. And you start producing a beta-hydroxybutyrate aldehyde that can become toxic. So we became interested in that. So we fed animals various ketone supplements, ketone salts, MCT, ketone salt and MCT combo, ketone esters, and 1,3-butanediol. And the short sort of summary is that 1,3-butanediol can cause changes in liver histology that indicate that it's compromising liver health. So when you metabolize 1,3-butanediol, aldehyde dehydrogenase and alcohol dehydrogenase, it involves, it's an NAD dependent reaction. So it depletes the liver cells pretty remarkably fast of NAD, and it also tanks their ATP production. So it's kind of, so if you are consuming 1,3-butanediol, or alcohol for that matter, your NAD levels in your liver are depleted and ATP is depleted. We know this, I teach, the medical students, and there's something called alcoholic ketoacidosis. So if someone's fasting, especially, and they're drinking alcohol, essentially what happens is that they cause a redox shift in the liver, ATP levels drop in the liver, and the liver can't produce gluconeogenesis, because gluconeogenesis is a very ATP-dependent process. And because they do that, that actually triggers runaway ketogenesis to cause alcoholic ketoacidosis. It's like de-energizing the liver. There's this redox shift from drinking alcohol. With 1,3-butanediol, you have the potential for causing that. In normal, healthy subjects, and our animals were healthy, young, healthy animals, and we still saw those histological changes of we saw a lot of red blood cells in the liver, and we saw this vascular congestion in the liver. So it was altering the blood flow. The blood flow was sort of backing up, and And it was also reported by another investigator that happens. And there was an elevation of TNF alpha too. And we saw that with the ketone ester, which was a 1,3-butanediol ketone ester and 1,3-butanediol. And we saw more fat globules in the liver. So there was greater fatty acid deposition, like in the liver. So that was after 4 weeks, but we also did like a 100-day trial too. So, but we did not see that with ketone salts, and we did not see that with the ketone salt MCT combination. So and I become concerned about this because prior to publishing that, we have a variety of different animal models from various disease states, like inborn errors of metabolism. And I have families that I work with that have children that have inborn errors of metabolism, and we had the mouse model of that. And what we observed is that many of these mice would die when we would give them 1,3-butanediol or a 1,3-butanediol-based ester. We have never seen that with, for example, MCT or the ketone salts. So that then becomes those animal models of impaired metabolism and aged animals too. Like older animals, we did an aging study where they were just dying from 1,3-butanediol or the ketone ester when we were using high dosage. And this was acutely. But we didn't know why they were dying. They would have symptoms of ketoacidosis. So we did a study where we actually incorporated into the food, and then we would gavage them at a lower dose over a protracted time frame. And then we took the livers out, and we did a CBC, CMP, and we did the blood. And we showed that there was sort of this accumulating toxic effect with 1,3-butanediol. But keep in mind, this is in the context of daily use, chronic therapy, but it was also in a healthy young animals. So my concern with 1,3-butanediol is the family that has the child with an inborn error of metabolism, that where therapeutic ketosis is helping the child, but it's hard to maintain ketosis. So they go to the market, Amazon, and they get a 1,3-butanediol supplement. And because that particular inborn error of metabolism impacts many kids with glycogen storage disease type 2, Pompe disease, they have fatty liver and they have compromised liver metabolism. So they are going to be like the canary in the coal mine. So I always think about those animals that we inadvertently killed because we were giving them 1,3-butanediol. So they become very sensitive to 1,3-butanediol. So you want to use a butanediol or alcohol-free ketone supplement in that context if you're going to use it chronically over a period of time. So there's many patients where that would, like older people using it for Alzheimer's, you want to take this like pretty much every day to get the benefits of it. Older people have a remarkably reduced impaired ability to metabolize alcohol. So alcohol becomes more toxic to them. So we can extend sort of the idea that 1,3-butanediol given chronically, especially at a higher dose to an older patient, is going to be significantly more toxic than the healthy athlete or the healthy guy just at his desk who wants to take, or ketone ester or 1,3-butanediol, intermittently. So that is theoretically maybe okay, but you also want to check your liver enzymes. So what I did, I took 1,3-butanediol at a high enough dose to keep my ketones into that 2 to 4 millimolar range, which a lot of people, for 14 days, and then got a comprehensive metabolic panel and a CBC. And my AST and ALT went up, but just above the upper range of normal. So it moved my transaminases, but GGT shot up. So if you really want to look at, how alcohol is affecting your liver metabolism, look at AST, ALT, but also measure GGT, because that's a more sensitive indicator of alcohol toxicity. You also want to look at the size of the red blood cells, MCV, I think. So there's the CBC will show, and I've looked at a lot of blood work from various people, and then when they send it to me, I'll see their GGT levels are elevated, and I'll see their red blood cells are enlarged. And I'll be like, can you be honest? How much alcohol do you consume? And they're like, I'm getting about 2 or 3 glasses per night, but they didn't tell me that before. And I was like, okay, well, your blood work is showing your AST, ALT are okay, but GGT is elevated and your red blood cells are larger. So I knew you were drinking alcohol. So, so for one thing, so try to get off that. And if they want to use a ketone supplement, I steer them away from a 1,3-butanediol based supplement.
So then if someone, they want to lean in a little bit more, probably the regular person probably wants to go for like a ketone salt, I would imagine. That's something that would be probably
You
the
can
most...
get to 1 to 2 millimolar range.
Yeah, and probably the most cost effective for people just if they wanted to do it daily.
Yep. Yeah, and it's also, you need to consider, so there's the D enantiomer and the L enantiomer, and this is of high interest to us because we never pivoted and went to just the D or the R enantiomer, which is kind of, your body makes mostly D and R, and then it makes a little bit of the L.
So we're talking D just for the regular people watching. So regular, there's DBHB and there's LBHB.
Yes, that's right. Yep.
So when you're looking at the labels, look
they're
at this.
mirror images if people can see and of one another.
Okay.
And they get metabolized differently. When you consume a racemic mixture like keto start, like your mixing. So you have the D and the L. When you consume a racemic mixture like Audacious Nutrition Keto Start, so what happens, the D gets into circulation and that gets burned pretty fast as fuel, very efficient fuel source. And then the L stays in circulation 3 to 4 to 5 times longer. And it also crosses the blood-brain barrier and gets into higher concentrations in the brain and into tissues, where it can be used as an energy source, but much slower. But the advantage of the L is that it's the time-release ketone that can also impact the signaling pathways. So suppression of the NLRP3 inflammasome, so it suppresses inflammatory signaling, including IL-1 beta. It's hitting a ketone receptor, which could decrease sympathetic tone or over-sympathetic dominance. It can decrease that. It can have epigenetic effects. So the enantiomers, both enantiomers, these signaling pathways do not seem to be enantiomer specific. So the take-home message is that D has effects and L has effects, and you probably want to get both of them together. The fast-acting one and the one that stays in circulation are very beneficial. And there was a study that was done in a porcine model, a pig model, in American Heart Association Journal, which is kind of like a gold standard journal, by a group that has a history of publishing great papers in high-impact journals. And they looked at the L versus the D, and they found that the cardiac output from L was 5 times higher than the cardiac output from the D enantiomer. And it wasn't an energetic effect. It had to do with a decrease in afterload. So when the heart is pumping, it's pumping against resistance. We call that peripheral resistance of the heart. So as the heart is pumping. So it's almost like if you have a garden hose and you're kinking the garden hose a little bit, so you need greater pressure to push it through the garden hose. Well, the LBHB seems to impact the vascular endothelium in a way that unkinks the garden hose, and that decreases the afterload. So this has become of intense interest to pharmaceutical companies because they've reached out and they want to hear more about this, and there's a high interest in the LBHB impacting the vascular endothelium in a way that decreases peripheral resistance because the cardiac output was significantly increased with this ketone. So it's almost like we have the L-beta-hydroxybutyrate is almost like, in many ways, like a drug form of VHB that stays in circulation longer. Some of it about 20% of it converts over to DBHB. So there's an interconversion. When you take a large dose of an L, and this is really important for people because when you take a racemic mixture, you're only measuring the D, you're not measuring the L, right? But if you consume a large dose of the L, like a significant dose, and you measure for the first hour, nothing, second hour, nothing. But then about the 4th and the 5th hour, it starts to go up. And that's because there's some interconversion of your L to the D. Another important thing is that someone who's never taken exogenous ketone supplement and they're in a state of ketosis, and you take the heart out, about 1/3 of the BHB in the heart will be L. So for reasons we don't understand, and I want to interview some of the authors that have published this work, there's a conversion of D to L in the heart. And maybe it has to do with that the D just burns really quick in the heart. So you just get the leftover L that's a slower metabolism. But independent of consuming any kind of like exogenous ketone supplement, there's a high concentration of L in the heart. And we don't know why, but we do know, based on very good peer-reviewed studies, is that the L is functioning as a signaling molecule that's decreasing peripheral resistance and significantly increasing cardiac output. And it's doing it through a non-energy related pathway. It's doing it through impacting peripheral resistance. So this has really big implications for athletes. This has big implications, obviously, for cardiovascular patients or patients that are navigating, have cardiac insufficiency. So that's the interest there. And that's why the various companies have reached out to really understand this. And I'm trying to understand it myself. But I think we can appreciate that these endogenous metabolites, the D and the L specifically has a remarkable signaling effect that we need to understand more, and we can leverage that to, it's amenable to a pharmacological intervention. So we could come up with various esters and even acids and salts of L that can be therapeutic in ways that we have not explored yet, that we're working on now, actually.
Well, I'll link out to some options down below too, because I think I know it can be hard to navigate this. But I mean, the takeaway is just
I'll send you my go-to ones.
There's a lot of options out there. I mean, I'll say just, without naming brands, just look on the label. And if it's 1,3-butanediol, just take Thomas's word on it. Just it's probably not the best option for you if you're what we're talking about, at least.
It'll give you a buzz.
It'll give you a buzz.
It has a mild euphoric and narcotic effect, but it's not something that you want to use chronically. And and I would steer people to the research. Also, 1,3-butanediol can create dependence. So if you're navigating that,
just be aware of that. So I mean, the ketone salts, obviously they're bound to some down to sodium, potassium, magnesium, but that's a little bit of a moot point, I guess, for the general discussion. But so I can link out to some below. But Dom, where can everyone find you, man?
Yeah, they can find me at ketonutrition.org, and also want to steer people to the Metabolic Health Initiative, which is the educational platform that we have. That platform also hosts the Metabolic Link podcast, which we interview a wide range of experts on these topics that are doing the basic science research and clinical research. And it's also ACCME approved or accredited. So so Keto Nutrition, Metabolic Health Initiative, and Metabolic Link podcast.
Right on, man. Thanks for that.